Rob, for putting this together at the last minute. And if there are any glitches, we'll work them out for the next time. Dr. Akselrod will take over now. Go ahead.
Okay, thank you very much. Thank you for bearing with us with the slight technical malfunction. And thank you for joining today. The goal of this presentation, this meeting, is to get everybody on the same page with regard to the novel coronavirus known as COVID-19. We are going to leave plenty of room for questions and discussion at the end, and Dr. Petno is joining me in order to discuss the hospital preparedness and operational protocols. And the rest of the infectious disease division, including Dr. Simon, Dr. Prenti, Dr. Siegel, and Dr. Roberts, are also physically nearby for questions at the end. So I'm going to give an overview of what is currently known, including updates. Some of the information that I will be presenting is still under investigation and in the process of peer review or validation. I will try not to present too many speculative pieces of information, and there is certainly a lot of conversation to be had about the next steps in this. I tried to source my information as much as possible from peer-reviewed sources and also from the Conference on Retroviruses and Opportunistic Infections, which took place earlier this week. It was meant to have taken place in Boston. Instead, in light of the pandemic, it took place in virtual space, and Dr. Roberts and I joined remotely. As we speak, specialty societies across the medical disciplines are putting out and constantly updating guidelines of what different fields should know, can help with, and what types of knowledge dissemination will be more useful for each field. There are some excellent patient information handouts in all of these societies up here, including the ACP and the American Society for Microbiology. And there are evolving conversations on professional forums within infectious disease, clinical microbiology, critical care, and emergency medicine, and I'm sure many others. So to give a little overview, this is the epidemic curve that I'm sure most people listening in are familiar with by now. In December of 2019, hospital in the city of Wuhan, China, reported a cluster of unusually severe and unusually frequent bilateral interstitial pneumonias with no obvious source. The local medical community rallied around diagnosing the illness and identifying a new virus. By the end of December, information about the cluster and the new virus was reported to the Chinese Center for Disease Control. From there, it was shared with the World Health Organization. By January 8th, the genome of the virus was sequenced and shared with the world scientific community. The genome was similar in some ways to that of the virus that caused the SARS epidemic in 2002-2003. Based on the genome and the work done in Wuhan, reagents and PCR primers were created in order to establish diagnostic capacity. Throughout January, the epidemic progressed in a very dramatic way in Wuhan, China. I'm sorry, I'm somehow annotating this this presentation instead of clicking forward. Here we go. In the days surrounding the Lunar New Year celebrations in China, millions of people traveled to visit friends and family, and the holiday travel is believed to have contributed in a significant way to the spread of the virus outside of Wuhan and outside Hubei province, and from there throughout the world. Although airport screening measures were implemented in January, and some travel restrictions were put in place. As we know, this was not sufficient to prevent worldwide spread of the virus. These are pictures showing people wearing masks on the street in Southeast Asia, and the cruise ship that was parked outside of Tokyo for many days while the virus was transmitted between passengers, and eventually the passengers were taken off the ship and quarantined in their home countries, including the U.S. These are aerial pictures. This was not 6 days ago. This is now more than a month and 6 days ago. But these are aerial pictures showing the construction of an emergency hospital built in Hubei province to take care of over 1,000 overflow patients ill with the new coronavirus. The epidemic curve outside of China, if you looked at it in February, would have looked something like this. This is a World Health Organization map. This is showing cases outside of China only. And in blue, it's showing increasing numbers of cases tied to international travel. Looking at that epidemic curve now, it is no longer even traced by international travel or local transmission. The role of local transmission in multiple countries has grown significantly since even 2 weeks ago. And you can see this graph is coded regionally with increasing, exponentially increasing numbers of cases
February
in Europe.
In a month. This.
Yeah, I'm sorry. I'm hearing someone's feedback on the microphone, but just to clarify, this is through March 11th. Now, this is the Johns Hopkins coronavirus map, which is a great resource that allows you to look at current as well as total cases, breaks it down by country, and within a country, within the US and Canada, you can look at states. I would like to call the attention of everyone to the graph in the lower right corner, where in orange, you see the number of the number of cases in mainland China, and you see that curve first go up with what seems like exponential growth, and then jump significantly when they change the case definitions, and then flatten after some very dramatic measures were taken in China. Now, in yellow in the same graph, you see the number of cases in all other countries, and we are in the US. We are currently believed to be in the upswing of that. So a few basics about the virus that is causing the situation. This is a coronavirus. It's not, as some people in the lay public may mistakenly call it. It's not just another flu, because it is not a flu at all. It is a coronavirus. It's similar to influenza viruses. It's an RNA virus, but with a high RNA replication error rate, but it is quite distinct from the influenza and the Orthomyxoviridae virus family. The coronavirus family, in a typical year, there are 4 commonly circulating viral strains, and commonly used multiplex PCR panels, such as the BioFire panel that we use at GW, will test for these strains. However, there is no cross-reactivity between the commonly circulating strains and the newly evolved virus, and that has led to some difficulties with testing for it specifically. The features that we think contribute to the high pathogenicity and high infectivity of this new coronavirus is that its high affinity of its S spike, which in the picture on the right you see, and on the upper right you see the red spikes illustrating the role of the S spike that binds to the ACE2 inhibitor, the ACE2 receptor in respiratory epithelial cells, and you see a 3-dimensional picture of what that spike looks like. In the table on the slide, we have some epidemiologic and clinical parameters of the novel coronavirus, including its case fatality rate, which is currently believed to be about 3%. There are some caveats to that. They have to do with the limited availability of diagnostic tools. But the data coming out of China so far, and also the data being gathered internationally right now, does support the 3% case fatality rate figure. The R0, or the reproductive rate of the virus, has been estimated with a range between 1.4 and 5.5. It averages out to about 3. So for every person who is infected and ill with SARS coronavirus 2, or the virus that causes COVID-19, if not isolated and if not precautions are taken, that person will on average infect 3 other people. And how does this compare to other epidemics? As you see in this table, the SARS epidemic of 2002 through 2004 had a case fatality rate of about 10% and a similar reproductive rate as the current virus. MERS, which is the Middle Eastern respiratory virus that has been linked to camels and has caused very high mortality rates in the people it infects, has a much lower R0 and is much harder to pass on. The coronavirus family, and specifically the relatives of the virus that caused SARS and SARS in 2002, 2003, and SARS-2, which is causing COVID-19. These viruses have been of concern to epidemiologists and ecology researchers for quite some time because of their high rates of recombination and high rates of error and mutation, which essentially predispose them to creating versions of themselves that can infect not only new individuals and possibly reinfect individuals that had previously experienced illness with a similar virus, but also to make jumps between species. So this is a virus with high rate of potential for causing zoonotic disease. And it has been investigated as such rather intensively since the days of the first SARS epidemic. As far as molecular data points us right now, the consensus is that this is primarily a virus that circulates in bats. However, it might have overlapped with an intermediate species, the pangolin, which is an animal that I'm sure many people didn't know existed until these past 2 months, but which is found across Southeast Asia and Africa, and is one of the world's most illegally traded commodities when it comes to its scales, which are used in some forms of traditional medicine, as well as its meat, which is considered a delicacy in some places. And also, it does look rather cute, so I can see how you might want one as a pet, which would be a terrible idea because, as it turns out, pangolins are highly susceptible to coronaviruses. So the base theory as to where this disease came from is in the wildlife markets in Wuhan, where either the virus crossed from bats to pangolins and back and forth, or was brought into the market and was amplified there in susceptible population. This is where the veterinary and ecology researchers tell us, we told you so, because these markets have been a cause for concern for quite some time due to them concentrating animals from different species that don't interact in the wild, putting them in close proximity to a highly mobile human population, and kind of setting up a condition in which a new zoonotic virus may either emerge or be amplified. So there's about a 96% homology between the newly circulating coronavirus and bat viruses that have been known to researchers in Wuhan, and a 99% homology with a virus that has been isolated from pangolins. The clinical features of the virus. So the initial cluster of cases, about 44 cases in Wuhan, were identified by the cause of fever, lower respiratory symptoms, and relatively high proportion of progression to severe illness. Numbers now on well over 1,000 cases that were studied in detail and reported, and then an even larger cohort that has been publicized since then, show that on average, 80% of people diagnosed with COVID-19 exhibit mild to moderate symptoms. These would be symptoms for which it would be safe to self-manage at home. 15% present with severe illness requiring hospitalization. 5% proceed to critical care requiring intubation and ICU care. And of those 5%, approximately half die. The average time from exposure to the onset has been consistently about 5 days, with a range between 2 to 14 days. And the duration of illness once the symptoms begin ranges from 1 to 2 weeks if it's mild, to a month and a half if severe and requiring ICU care and prolonged recovery. The shedding of the virus, the threshold to detection by PCR, is highest in the first few days of illness, although it may be hard to determine when the illness truly started. And then the shedding is continued for 7 to 12 days. There is no data right now on how long the virus may be shed in immunocompromised people. The key piece of information here is that viral shedding can occur 24 to 48 hours before symptoms start, and that has really important implications both for clinical evolution of the syndrome and for contact tracing, prevention of secondary cases, and public health measures to arrest the epidemic. Among close contacts, so those are household contacts, if no precautions are taken, the attack rate is about 10%. And this is a good time to mention that we truly don't know what the denominator is in terms of how many people might have had asymptomatic illness, because we would need serologic testing to answer that question, and we are probably weeks from those tests being validated, operationalized, and distributed. They are being done in some research labs, and we should have answers. But to give context to these numbers, a 3% or so mortality rate is 10 to 20 times the mortality rate that we would see in an average influenza season. The mortality is not distributed randomly throughout the population. I can share this in more detail, but I will move through it for the sake of time. I'll just pause for a moment on the radiographic findings. So the classic radiographic finding is bilateral multifocal pneumonia with an interstitial pattern. There are now high quality studies involving large numbers of CT scans. However, while this finding has a high degree of correlation with positive PCR testing for the novel coronavirus, in a population where that coronavirus is the dominant circulating strain, such as Wuhan and Hubei province in China, where those studies were done. In a population somewhere else where there might be other competing viruses like seasonal influenza or non-viral pathogens that cause multifocal pneumonia, seeing a CT scan like that does not give you the answer. It may simply support or not support your presumptive diagnosis. So I shared this slide with our residents about a month and a half ago, asking them if you'd seen this patient, would you suspect that there was anything unusual about him or her in a relatively young person without comorbidities presenting with fever and fatigue and respiratory symptoms in the middle of flu season in Seattle. That patient had given the doctors a history of having just arrived from China, and based on their clinical suspicion, they proceeded with testing for the novel coronavirus, which was in fact detected. And then the patient had about a 10-12 day hospital stay and duration of cough that continued past discharge. So going back to the largest available data sets, so some data from China, and again, this is a relatively small number of cases that were later backed up by much larger cases. Fever, while initially considered a defining feature of the illness, is not always present on day one. It may present several days into the hospital stay. Only about half the patients in the largest cohort reported had fever on day one, but about 90% of them had fever at some point in their hospital stay. Cough also, as you see, is not always present, and cough may not be present on day one either. The clinical progression of COVID-19 appears to be somewhat less precipitous than the flu. So people may present with somewhat milder respiratory symptoms that progress to respiratory failure over a period of a week or so. And the distribution of mortality is quite uneven. So even though patients in the older age groups accounted for relatively smaller fragments of the population that was exposed and became ill with COVID-19 in China, the mortality rate in people over 65, 70, and especially over 80 is quite concerning. The people at highest risk appear to be those over age 80 with a 15% mortality rate. And I want to leave the slide up for the moment because it makes us think of who the U.S. population is now that there's evidence of the virus being transmitted on the community level. It makes us think of Seattle, where the virus may have circulated relatively undetected throughout the community until it hit a nursing home. And then a large number of people developed advanced respiratory symptoms and required hospitalization and advanced care all at the same time. So a couple more notes on high-risk groups based on the cohorted data from China. Cardiovascular disease, hypertension, and diabetes, as well as pre-existing chronic respiratory disease all correlate with higher rates of mortality. There was some question about whether baseline levels of chronic respiratory disease on the population level in China contributed to the high mortality that was observed due to the high levels of air pollution and also high prevalence of smoking. It is not entirely known what proportion of the mortality may be attributable to these factors, but we certainly know now that it's not only patients with chronic respiratory disease who suffer fatal outcomes. About immunocompromised patients, so that is probably the most conjecture-prone part of the presentation because there's no reliable data on how many patients involved so far were truly immunocompromised. There is some speculation that patients who are neutropenic or who have advanced HIV and low CD4 counts would have a higher risk of mortality. However, this is a new virus and we don't entirely understand how it behaves. And when it comes to people with HIV, their main risk factor for mortality may not be low CD4 counts when we think about the greater population of people living with HIV, but rather be their age, as more than half of our HIV patients are now over 50 years old. About pregnancy, so because the virus has only been circulating in the human population as far as we know since December, there's only data on women in the third trimester of pregnancy. Their maternal outcomes appear to be similar to those of uninfected women, and there's no clear evidence that the virus can be transmitted vertically or perinatally. There was one case reported in which a neonate tested positive for the virus within mere hours of birth, but that may have been due to exposure to healthcare personnel due to lack of proper precautions. And then what actually causes the death, the mechanism of death is, or the mechanism of respiratory failure and fatal outcomes is ARDS. And that is a feature shared by the new coronavirus with its predecessors, SARS and MERS coronaviruses. It's also shared with influenza, both seasonal and pandemic strains. The interesting pathological findings on autopsies coming out from the Chinese reports right now is relatively high rates of pulmonary fibrosis. And while an acute viral pneumonia may seem like a very quick mechanism when you think about progressing to pulmonary fibrosis, you have to keep in mind some of them are ill for a month prior to death. All right. I can give a couple overview pieces of information about pharmacologic treatment candidates. To talk about them in detail would probably require another hour on its own. So there are ongoing studies to establish efficacy and safety, and there are also efforts to repurpose existing antivirals. So Kaletra or lopinavir ritonavir has been studied against MERS, as has been ribavirin. Those mostly showed promise in animal model studies and not so much in human patients, although with MERS, the total number of people infected globally has been low since the disease was first described. So the numbers are not very reliable. There is antiviral, remdesivir, that has been initially developed and studied in Ebola and appears to have broad antiviral activity. The NIH is currently enrolling patients in a trial, and there are also Gilead offers some compassionate use applications of the drug. Broadly speaking, the compassionate use is available for patients who have severe illness and are already intubated, whereas the clinical trial is available to patients who are definitively diagnosed with the novel coronavirus, but can consent and can participate in studies, and for us, if they could be transferred to the NIH to be part of the study there. There is, and again, this is very preliminary data, but there appears to be some activity of IL-6 inhibitor tocilizumab sold in the U.S. as Actemra in ARDS related to this virus. This would primarily apply to patients with severe illness, and we don't have well-established numbers on its efficacy and numbers needed to treat to make a difference in an outcome. We are following the information that comes out of it closely. About the vaccine development, there are, again, as part of the work right now on trying to repurpose existing antivirals, some companies are also looking at repurposing existing vaccines. So back in 2002, there was a major, 2002-2003, there was a major push to develop a vaccine against the original SARS virus. And when the novel SARS virus that causes COVID-19 became an issue of global concern, there began a big push to repurpose some of that vaccine to see if it might have immunogenicity against the new virus, as well as to start from scratch in identifying vaccine candidates. So there are currently multiple companies racing towards the development of a vaccine. And it will probably be at least 2 months before there's data coming out of those trials. In the best possible case scenario, if we have a vaccine candidate within 2 months, that can be after that scaled up and distributed globally, it would still mean multiple months to implementation, and that's assuming it looks good in safety testing. So what can we do for the next weeks to months if the epidemic is on our doorstep and the vaccine is months away? So this graph, which was designed by an epidemiologist at the CDC and then popularized by The Economist magazine and has been circulating on social media over the last week or so, spread and promoted by epidemiologists and public health people. And I hope we've all seen it by now, but it's a handy visual illustration of how we might approach a world in which we don't have pharmacologic interventions or vaccine interventions against the virus yet, and are trying to keep the number of cases manageable so that our healthcare can actually handle the cases of severe illness. So, the original interventions to prevent spread of the virus mainly relied on travel restrictions. We now have a month and a half of data, both real world and in the medical literature, about why that didn't work. Why it didn't work is that the virus is can be transmitted for 24 to 48 hours before there are symptoms, and people's symptoms may be very mild, and the classic symptoms of fever and cough do not present on the first day necessarily. Models that try to explain how effective airport screening, say screening people for fever and respiratory symptoms and telling them not to travel if they have those models missed about 46% of people who were infected. And that's what we think happened in the real world. So we want to take a step back and think, what did we do in the days before we had vaccines and before we had antivirals? This is a picture from the National Library of Congress showing Walter Reed Hospital back in 1918. This is an influenza ward. So the only means available for caring for patients were supportive care, sunlight, which has ultraviolet activity thought to provide some measure of disinfection, and circulation of fresh air so as to avoid trapping the virus in with other people and recirculating it endlessly. So Washington, D.C. lost about 3,000 residents to the 1918 influenza. There's a fantastic book by James Barry called The Great Influenza, but the world's deadliest plague. I highly recommend it. And it talks about the measures taken by different cities as the pandemic influenza of the day was making its way through the world. Philadelphia, which was a busy port and the large influx of soldiers carrying the virus, basically proceeded with holiday celebrations, parades, and public life, whereas St. Louis essentially isolated itself. And the mortality rates, the mortality difference between those two cities was quite dramatic. So where we find ourselves right now is the epidemic is winding down in China. The last couple of headlines I saw about the Chinese public health response is that they're letting people leave their homes after completion of a 2-week nationwide quarantine or reverse quarantine. And the Chinese public health authorities are now starting to look extremely closely at people coming into China from other countries where the epidemic is not under control. Italy is currently the country with the steepest rise in deaths. Over 800 cases have been reported as of today. Over 800 deaths have been reported as of today. And the reports, if you want a good scare, I invite you to look at reports by physicians and medical staff in hospitals in northern Italy right now describing an absolutely disproportional number of cases compared to the resources they have. And this was a fully functional, fully modern medical system just a few short weeks ago. So a little bit of modeling to support what happened in China. There's some, for people who are really into modeling, come talk to me. But basically, if you make little mathematical compartments of what proportion of your population has never seen this virus before and is susceptible, and then they get exposed, and then they become infected and are infectious for a while, and then they either die or get better and they no longer pass the virus, and then there's some question of can those people be reinfected or not. But you can create a model for any infectious disease and estimate how the virus transmission will behave. So based on observed data from China, there was a marked reduction in the R0, or the infectivity rate of the virus, after the red line in the graph happened in late January, after severe restrictions on movement and interpersonal contact were imposed. And then in the model on the lower left, they actually asked the question of, well, what if you have a completely new city and patients infectious with the virus of COVID-19 lands there? Does it necessarily result in an epidemic? Well, not so fast, but in that there is certainly an element of chance about as to how many susceptible people that person will come into contact with and how effective they will be in transmitting the virus. But the takeaway from the graph on the lower left is if you introduce the virus into a naive population enough times, and it's a contagious enough virus, then your certainty of establishing local community level transmission approaches one. So this brings us to last night. Mayor Bowser declared a state of emergency in DC, and there were also some more national news conferences regarding measures that are being put into place. There is a call open to all physicians and medical providers by the DC Department of Health tomorrow to talk about what exactly those measures mean on the local level. And I want to go a little bit more into our testing algorithm and the role of our lab and the Department of Health labs. I do have a message from Michael Knight, who graciously ceded his grand round spot to me so I could talk about all this, which is that we have to put on our own oxygen first in all this. The strains, the stress of even reading about this virus and what's happening in other places of the world is substantial. And the challenges that I think all of us are facing right now is that this is likely to result in a high load of clinical cases on top of significant burdens that we already carry, significant stress for the health of ourselves and our loved ones, questions from our loved ones, sometimes repetitive questions from our loved ones, and then practical arrangement for child and elder care when people start taking into consideration, have I been exposed? Should I be visiting my grandmother? And the potential for feelings of a lot of personal responsibility and guilt. And Michael and I want to share that we want there to be open lines of communication about the stresses we'll experience. We want to know that it's not selfish to put on your own oxygen mask first, so to speak, maybe a bad metaphor for a respiratory illness, but we do have to be mindful of our recovery time and our own health throughout all this. All right, these are good practice tips as recommended by the CDC and other organizations regarding what to tell patients and loved ones and ourselves to do for personal protection. So as a reminder, wearing respirators or face masks on the metro is likely not effective on the population level. However, instructing everyone to be mindful about washing their hands is because of the significant role of fomites in transmitting this virus. And the strategy for managing the coronavirus, in addition to measures like social distancing and interruption of travel, really boils down to, can we determine who has it so that we can isolate them and prevent transmission onward, as well as manage them appropriately medically. So what I have up on the screen right now is the MFA algorithm for testing. I want to spend a couple of minutes here, and I'll go to the hospital algorithm and cede the floor to Dr. Petno. So first of all, what does testing mean? So the currently available test for the virus is a PCR test. It is not part of existing multiplex panels like the BioFire panel. It is not a point of care or immediate test. It is a PCR test that is run in a specialized lab using first RNA extraction reagents and then the standard PCR methods. The labs that currently carry this test, if I was giving this talk a week ago, I would have said the only venue to get tested would have been public health labs, which received their kits from the CDC, which developed the kits over the last month and a half. For the past week, commercial labs like LabCorp and Quest have come on with their versions of the test. And those are suppliers that we trust to do proper validation. There may be additional labs offering testing with which we're not familiar, but for the MFA and for the hospital, we're sticking with vendors we know and trust very well. The turnaround time for tests with the Department of Health is 1 to 2 days currently. With commercial labs, the range they give us is 3 to 5 days, and there's variable availability on weekends. So what we want to think about is who do we test for the coronavirus and what the clinical or decision-making utility of that will be. First of all, this is for patients that are already presenting. If they haven't presented, if they're merely contacting us by phone, right now for people with mild symptoms, it is reasonable to advise them to remain at home, self-monitor, avoid contact with people as much as possible, and therefore avoid spreading the virus. For people who are presenting for medical care, if they report fever and cough or shortness of breath, so both fever and lower respiratory symptoms, you definitely do not miss testing them. What you want to do, though, is you want to exclude at the point of care influenza, and then think about what besides the novel coronavirus might they have. If you're seeing them and if you're testing them, then what you should be testing is not just the coronavirus. All right, so that said, for people with fever and cough or shortness of breath, they present, we screen them for high-risk features, such as known contact with someone who has been diagnosed with COVID-19 or travel from high transmission areas. And that list is updated almost daily. But right now, if they came from Italy, that would be an extremely high cause of concern. If they're a resident of a nursing home or long-term care facility and they have the classic symptoms, that is reason to test them because nursing homes are the most vulnerable places with the most vulnerable people in this. And we would not wish to miss an infection. The test involves a nasopharyngeal and oropharyngeal swab, and those would be done both for COVID-19 and for the multiplex PCR panel with BioFire. If we run out of either the nasopharyngeal or oropharyngeal swabs, we will reassess and alter. But right now, we really would like to get both because there are some patients may be difficult to get a good oropharyngeal swab if their tongue is very large or airways obstructed. And some patients do not tolerate a good nasopharyngeal swab. And then you want to make sure you can get hold of the patient if you're sending them home or if they're going to be admitted. All of this would be happening in the ED. All right, and then the rest of the algorithm, if they don't have very obvious features, if like being in contact with a known case or living in a nursing home, you still want to think about their risk category. So are they older? I'm cautious about how I'm defining older, but do they have a history of travel from, say, New York or Seattle currently? Do they have chronic medical conditions that would place them at higher risk of mortality if this were the COVID-19 disease? So cardiac disease, high blood pressure that's uncontrolled, those would be risk factors for poor outcome. Are they a healthcare worker? And then immunocompromised patients, as I mentioned, there's no good data on this, but we usually exercise an abundance of caution with them. And I would put pregnant patients in that category too, even though, as I said, so far it looks like pregnancy outcomes are not affected. So then you want to rule them out for influenza. You want and if they're negative, then you do the nasopharyngeal and oropharyngeal swabs. And then make sure you can get a hold of them with results and that the patients get good guidance on avoiding possibly infecting other people. Right. And with that, I'd like to transition to our discussion of the hospital protocols.
Bruno was gracious enough to come by and help us with this talk, and he's going to go over the hospital protocols now, and he's going to skip his usual thank yous and all that he usually does. Bruno, go ahead.
Thank you, Dr. Wasserman. On that note, as you can see up on the slide, we have two processes of testing. One is really focused on the emergency department, how to rapidly identify, isolate patients that are of concern, and then perform appropriate testing for COVID-19 as well as the differential diagnosis. These patients are then either contacted with DOH to do the testing through the DC Department of Health, or as Dr. Akselrod already brought up, commercially through LabCorp, with that test taking 3 to 5 days to return. For patients that we feel need to be admitted, a more urgent test through the Department of Health is the preferential way of testing such patients, and COVID-19 precautions such as contact and airborne are put in place for those patients. We have done this on a significant number of patients thus far through the emergency department, and all of those patients, except very few, we've been able to discharge safely from the ED to be followed as an outpatient. The algorithm that you have here in front of you is the algorithm to be used if an attending physician feels that a patient that is hospitalized currently would need or benefit of a COVID-19 test. As you can see here, safety is number one of staff as well as the facility, so appropriately contacting the right personnel as well as making sure that the right precautions are in place, meaning contact airborne precautions. Using differential diagnosis testing, the likelihood of the patient having COVID is then determined, meaning a respiratory panel or other tests that may yield a diagnosis to explain the patient's symptoms. If the physician attending in this case still feels that that is not something that can be ruled out, then contacting the appropriate hospital leadership to obtain a test for COVID-19 is the next approach. And again, the hospital leadership, infection prevention, myself and others will work with the DC Department of Health to see if that testing would be done by the DC Department of Health or if it would be done commercially. Until the test returns and results, the patient will be assumed to be COVID-19 just because they're under testing, and all precautions will continue as well. We are putting guidance together currently for staff members that are taking care of confirmed COVID-19 patients, either who've been in contact with them in the ED or up on the floors. Most important to ensure everybody's safety is to ensure the proper use of PPE, meaning having the face shield, having an N95 mask, having a gown on and gloves, and performing appropriate hand hygiene, because we cannot stress the importance of hand hygiene enough. So I'll turn it back over to Dr. Akselrod at this point. Thank you.
Hana, you finished at this point?
Yes, this is our last slide. We'd like to open to discussion.
So while we try to set up for questions, I've had a couple people text me questions. If you'd like to Tiger text me or Hana questions, we'll try to answer them while we get set up. The first question was, can you give an opinion about stopping ACE inhibitors or ARBs as the unregulated ACE2, which is part of the critical pathway for lung progression? Hana?
It's theoretical. Some of the cardiologists are.
I can't hear you.
Yeah. No, well, Dr. Simon, I will huddle for the microphone. No good clinical data available. There is a theoretical utility to it. If your patient is already in critical care and intubated, that's an easy decision. If your patient is older on an ACE inhibitor or ARB and at risk of progressing to more severe illness, I don't think anyone knows for sure right now.
So some of the cardiologists are recommending that you stop that and go to an alternative agent.
So another question is, what is the accuracy of the test?
Depends on what you're using to validate. I won't get into the long debacle of the CDC kit and how well it correlates with the WHO's testing kit and how well it might correlate with commercial labs, simply because I don't have access to that data. And I don't know that any of us do. We are using the tests available to us. The other part of it is, what's your gold standard? if you're trying to establish accuracy. Right now, the gold standard is detection of viral RNA by RT-PCR from a fluid or tissue sample. Someday, when serologic tests are available, we'll be able to establish what proportion of population has had the infection and establish true positive, false positive rates, perhaps. But right now we don't know.
Okay. Any idea of how soon after infection someone will test positive?
So the range is, if by infection you mean the beginning of clinical symptoms, then 2 to 14 days with an average of 3 to 4. But if you mean after exposure, then there might also be an incubation period during which people might theoretically test positive. The most reliable window for testing appears to be between 3 and 7 days into the course, with an average of 5.
Hana, is there any data on the use of steroids in someone who might have an exacerbation of asthma or COPD? There's been some implications that steroids might worsen, although there's been some implications that steroids are being used for pneumonia.
So similar concerns as with every other viral pneumonia. Unfortunately, we don't know anything specific to this infection because you're trying to balance their underlying respiratory illness with the theoretical risk of worsening the infection. Dr. Simon?
In the elderly, the steroids are probably not useful, especially if they are getting sick, especially in the later course of their disease. There are some young patients who are dying very early. It's a small minority, but in those, they're probably dying from an exuberant cytokine response. Perhaps in that population, steroids might benefit. There are some people who are giving an anti-IL-6 drug to those patients.
Hana, can you get the flu and have COVID-19?
Yes, in theory. In practice, co-infections appear to be rare. Flu season is winding down, is what the CDC tells us. So as we move forward into the spring, this may be an even lower concern. Right now, our algorithm treats it as though you can't have both. Is it possible to have both theoretically? Yes.
Okay.
There is a question of seasonality, and does it have anything to do with the coronaviruses? And the issue is, first of all, no one studied this virus in particular, and most of the studies were actually done in flu. Second, the concern that, with warmer and more humid air, the virus cannot be traveling as far when someone coughs and aerosolizes because it encounters other droplets in the meantime and precipitates out. That concern, we don't know how much it applies to the current virus because we don't know how much aerosol transmission plays a role. Based on some data that's in pre-publication right now, the aerosol may hang out in the immediate environment of the person coughing for a couple hours after they cough, which is why the CDC currently recommends airborne precautions for anyone who's manipulating patients or pharynx in any way or is taking close clinical care of them.
And there's been a couple of questions about immunocompromised patients and transplant patients. Should they be treated any differently?
If they're on an IL-6 inhibitor, you probably don't want to stop it. It's the best I can do.
Okay. Bruno, you had a question?
I just want to highlight also that I'm monitoring the respiratory biofire panel results very closely. 3 out of the 5 that we did yesterday in relationship to COVID-19 actually came back for a coronavirus. It's one of the 4 seasonal coronaviruses and not COVID-19. I just wanted to highlight and stress that this may lead to some confusion in possibly healthcare providers, but certainly our patients when we tell them that they have a seasonal coronavirus infection, but that does not equate, of course, COVID-19.
So I didn't get a chance to get to all the questions. Please don't hesitate to call Hana or Tiger text her directly with any questions, but she does not have answers to policy questions, which is why I didn't ask those questions. Those are questions for the administration, your PGA, or a chair. Do not ask Hana those policy questions because she will just have to pass them on. I want to thank her immensely for putting this together at the last minute, for Dr. Knight, who we bumped, but we'll get back on the schedule, and for Bruno and Dr. Simon for coming. I hope this worked out well. I will get back to everybody if we'll continue this, which we probably will for Grand Round starting next Thursday. Thank you all. Thank you most of all to Hana for putting this together. At this point, we're concluded.